Hello, my name is Dr. Ismail Ghanem. Today I have the great pleasure of presenting this interesting case to the American College of Physicians Arkansas Chapter. The title of this presentation is Profuse ileostomy fluid losses as an initial presentation of Ochrobactrum Anthropi Bacteremia. A 59-year-old male with ileostomy presented to the emergency department because of fever, chills, and this left lower quadrant abdominal pain, which he described as a dull ache, rated 9 out of 10 in intensity. He also endorsed extreme fluid losses in his ostomy bag, requiring 10 bag changes per day, which was unusual for him at the time. Initially, upon workup, it was found that he was in severe shock and he had to be started on vasopressors. Blood pressure initially was 97/52, and he was also placed on 2 liters nasal cannula. All those saturations were quite good. Laboratory data reflected hypokalemia, a mild leukocytosis, and 5+ bacteria. He was started on IV Rocephin, Flagyl for gram-negative and enteric coverage, and sent to the ICU for pressor weaning and further workup. Cultures later resulted Klebsiella saprophysitis in the urine, as well as blood cultures growing gram-negative rods, which were later found to be Ochrobactrum Anthropi. Initially, the sensitivities and the speciation showed this particular pathogen, and the patient was switched to Levaquin and did quite well and was discharged on the Levaquin, which was quite nice because of the one-to-one bioavailability, IV to oral. Before he was discharged, repeat blood cultures were negative, as a result, and his fuse port was removed, shortly after that. So this particular pathogen is a urease-positive bacillus, non-lactose fermenting gram-negative rod that's oxidase-producing and aerobic, and is classified by the CDC as a group 5D, and right now it's under the genus of the Ochrobactrum. It's been found in human sources and disease and other disease environments, and the unusual thing about it is because it's quite rare, and does have a low virulence. However, in certain circumstances, it does present with symptomatology and can cause disease states, but typically these might be meningitis, pancreatic abscess, and things of this nature. Also, catheter-related infections, and it does have a predisposition to cause disease in people with invasive medical devices. And this particular patient did have a infuser port, which could have also been a source. Typically, when treating Ochrobactrum Anthropi, we have to be very cognizant of this resistance, and it is resistant to beta-lactams, particularly cephalosporins, penicillins, and other antibiotics. But for the most part, levofloxacin, Bactrim, quinolones work quite well, and as I alluded to earlier, Levaquin is quite nice because of the 100% bioavailability associated with it. Over here to the left, in figure 1, we have this particular bacteria growing in a blood auger, and on blood auger, it does not show any type of hemolysis. So thank you very much for listening to this presentation. We see shock and these things are very common to see on an inpatient basis, but very rarely do we see ileostomy fluid loss as a result of Ochrobactrum Anthropi. So that's why we thought it was quite interesting to present.